on the right video, isn't it? Okay, watch the capsulorhexis here. As I first initiate the capsulorhexis here and I start to bring it up, you're going to see that it tears out underneath the capsule. And I recognize this right here. So what do? Watch the forces of the needle to bring it back. In the beginning, I'm going to back that up and show you, I'm not pulling towards me anymore, I'm pushing the capsule towards the center of the eye to make a very sharp turn here. And I'll go back and let's look at that again. Okay, because it's a very important maneuver. When the capsule starts to tear out, I stop and then I hook the capsule and I push it this way. Not this way, I push it this way. And then it starts to come back around. So you have to overcompensate for the direction in which you pull the capsule. And once I pull it this way, I start to recover. Okay? Now I can pick it up with my capsulorhexis forceps and complete the tear.
Yeah, when that starts to tear out, it's a good idea to reinflate it.
Right. Dr. Katsev just said what I didn't do was that maybe at that point I should have reinflated with viscoelastic to open the anterior chamber greatly, push back again, and decrease the radial forces as it went out. Actually, the only reason I didn't do that was I knew I hadn't lost a lot of viscoelastic, and when I pushed, it started to turn very easily. But it just shows you how quickly that can happen. So the next video I want to show you is a kind of an edited video, but it also shows the Varian system. This is a femtocataract that's been done, and here, this is the automatic tracking of the Varian system. And in the Varian system on the LensX laser, it takes the pre-op data that recognizes blood vessels in the iris, and it rotates the treatment in the femtosecond laser so that it aligns to where the axis, to basically a baseline, so that the axis of astigmatism from the preoperative measurements are lined up. It decided and it placed the incisions exactly where I wanted to at 0 and 120 degrees. So when we get into the operating room, there on the operating microscope is the Varian unit also, and it has now registered the eye, and it has shown me where, and I can confirm that because it lines up with the incisions that are made on the LensX laser. So I'm going to back up here just a little bit more. So the phaco technique when you do the LensX laser is a little bit different in that you have, in my case, a cored out central 2 millimeter and 2.5 millimeter ring here that has softened the nucleus all the way down to the bottom. The capsulorhexis has already been cut. I'm going to put in the viscoelastic after opening the side port and the keratome, or the laser incisions. I'm going to pick up the capsule and pull it out. So that was the capsule coming out. Now I'm going to hydrodissect, and I tend to hydrodissect a little bit more gentle because often there's air behind the lens and the capsule. And you can see with even just gentle hydrodissection, as I move the lens around, the air from behind the lens came forward there. I'm sorry, I'm a little off video. So that my technique here is to take the phaco tip and using very low ultrasound power, as you can see here, I go down and basically core out that 2.5 millimeter circle down about 70% depth. And here you'll see when I crack it, even though the crack incisions do not go very peripheral, they do go very deep. And I will push on the different quadrants, and you will see that the lens will separate easily into 4 pieces. You can see it broke there, it's broke here, it's broken here now. And I spread those open. Now I go into a non-torsional phaco, a longitudinal phaco, engage the tip with the bevel flat against the surface, and if I can't get it, oftentimes with the femto, because you have such a small core in the middle, the pieces tend to lock each other in. So you have to push the pieces away to unlock it and pull the pie piece out. Sometimes I'll just keep rotating until I get one piece out. And now that I got one piece out, I'll switch to regular torsional phaco in a second, and then take the rest of the pieces out. You can see that they grasp very easily. They're very large pieces, and they come forward very easily. And again, all the phacoemulsification is done at the iris plane and in the center of the pupil. The CDE for this relatively, you can see this is a fairly yellow cataract, and the CDE at this point is still only 1.9. And again, these are showing you all the important principles. Once you get occlusion, then vacuum will climb very, very quickly. The lens will either aspirate. If it isn't aspirating, then I just add a little bit of foot positional 3. As you can see here, this is the torsional phaco. There's very little phaco going into this eye. INA is also different because the epinuclear shell in the cortex is cut about 100 microns below the capsula rhexis. So there's a very distinct edge. So I go right up underneath the anterior capsule and I grab the cortex right at the lip of the capsule, and once it engages and the vacuum starts to build, then I pull it away, and typically the whole piece will peel out all the way down to the center of the lens. When we first started doing femto, it was really funny. The phaco was very easy, and all of a sudden people who were very adept surgeons were sitting in front of a room full of people and they couldn't INA the cortex. They just couldn't even find a piece to grab. So you have to modify the technique. But once you modify the technique and get used to it, it's actually easier than chasing the tags all over the place because you know exactly where the edge of cortex is. It's right under the anterior capsule. So now the Varion is turned on and it's tracking the eye, and you can see this movement as the eye moves, that as it moves around it stays on there. I'm putting the viscoelastic, and this is showing me the axis of the toric lens that I'm going to put in as it aligns to the Varion diagnostic unit picture, so it shows that the axis, where the axis aligns, even if the eye is rotated. I was one of the I think I had the 15th Aura unit in the United States, and was one of the people who really was instrumental in talking Alcon into purchasing it, and I was a participant in the toric trial that was done by WaveTech for the Alcon lens. So I'm very confident in the Aura, and what I've been surprised is as I've gotten confident in the Varion, that almost all the time they're the same. And what I didn't show you here was before I did that, I did intraoperative aberrometry, and I marked the pupil, and these were my marks on the pupil that I made by the aberrometry. And what I found is that if my aberrometry marks and my Varion axis, as this shows, are in the same place, I go by the Varion, and I will just line the lens up to the Varion, and then I will check the power and the outcome with the Aura again. So you can see here's the marks on the lens lining up exactly with that line from the Varion. All right, so we're going to move on. I wanted to share those videos with you, and now we're going to talk a bit about enhancement techniques and the results for enhancing premium IOLs. As Dr. Katzev alluded to, in the United States, the expectation of the patient for an almost plano perfect outcome has become the standard, okay? And if I'm off by 3/4 of a diopter of astigmatism or even a half diopter of sphere, I often will have to take these patients and do some corrective measure to make them happy. So I think it's important, and we haven't talked about here, about where do we go wrong and how does pre-op planning not work and lead us to the wrong answers. Well, we have errors in biometry, in axial length is one of them, but with modern OCT or immersion ultrasound, axial length is almost never a problem. Keratometry, both magnitude and axis, are a problem, and I think the problem is that we still, to this day, do not have a keratometer or a device that gives us reliably the true corneal power. And if the patient has any dry eyes or any external eye disease, then very often their cornea is not perfect. I have 5 keratometers that I use, and all these patients get keratometry on, 5 topographers and a lens star. And when they all say the same thing, I know I'm going to probably get a good outcome. But when I have wide variations between them, then I know I have a problem of keratometry, magnitude, and axis. We try to prevent these by treating these patients preoperatively until we get reliable measurements. As we all know, the other parameter is the assumption of effective lens position in the formula and the formula errors that are generated. The risk factors beyond the problems with just a normal eye include prior refractive surgery, an irregular corneal surface or astigmatism, like I said, due to either ocular surface disease, previous corneal disease, or anything that affects the ability to measure that cornea. And finally, we all know that both long and short axial lengths cause more errors with our formulas. So how about toric axis error? Well, when we're doing limbal marking and we're sitting the patient up and we're trying to mark 9 o'clock and 6 o'clock, studies have shown that those marks have as much as 5 to 8% of error. So with intraoperative aberrometry, as Dr. Katz has said, poor patient fixation, poor wound design that requires excessive hydration, letting the ocular surface deteriorate during the case, or deteriorating from the topical anesthetics, and interestingly, vitreous opacities can give a false error in the aberrometry also. So it's always important to be watching on the aberrometer screen the aberrometry grid so that you can see if there's voids in there from a vitreous opacity. You can also have an IOL rotate, as Doug talked about, with the removal of the viscoelastic, or if you have a wound leak and the eye gets soft, very often the lens will rotate. The other cause of rotation is high myopes and very large eyes. Often have very loose capsular bags for the size of our toric lenses, and those will also be off-center. As Dr. Tuyen talked very eloquently today about LRIs and AKs, but again, these must be on axis, and if we have an error in marking or an error in determination of axis, then we'll lose effect, and if they're not centered on the visual axis, we can actually induce higher order aberrations that will especially disturb a multifocal lens. So, the worst thing is that the patient's about a week post-op and they're very unhappy already, they're starting to complain, and you realize that you're probably off target. I think the important thing in the beginning for us all is not to panic, okay? We have to expect that we're going to have these kind of errors, and we have to anticipate these kinds of errors, or we should not be doing, in all honesty, premium refractive surgeries. So there's a number of ways that you can do corrections, but the timing of them all is always somewhat difficult sometimes in determining whether the patient is unhappy just because of an error in the outcome from a refractive point of view, or is the patient intolerant of multifocal lenses and they're not going to get happy no matter what. And the problem is that if you're going to do a lens exchange, you would like to do that lens exchange as early as possible and check, because then the capsular bag hasn't contracted and it's much easier to get the lens out. But it hasn't been enough time for stabilization of the refractive error, and it hasn't been enough time for the patient to neural adapt to the lens. So often there is a quandary as to whether to remove the lens or to wait. I have successfully explanted these lenses over a year out, and it can be done, but it is certainly not fun. Undercorrected limbal relaxing incisions, especially made by the femto laser, can be reopened at the slit lamp to get additional effect, and they can also be extended with a diamond knife at the slit lamp, and that can be very effective. Again, I like to do a YAG laser capsulotomy prior to any enhancement on any of these procedures, because there may be a slight shift in the effective lens position, and I don't want to get everything perfect and then 6 months later have to do a YAG capsulotomy. Again, this is a little bit of a hard decision if the patient is unhappy, because if you do the YAG capsulotomy in, for instance, a multifocal lens, and the patient is bothered by the halos and the aberrations of the lens, then IOL exchange with an open capsule is much more difficult than with a regular capsule. So, what are the timing of enhancements that I really like? Well, I really like to wait at least 3 months for the patient to stabilize, okay? And during that 3 months, we are very active with the patient. We're very active in treating any ocular surface disease that has cropped up as a result of the surgery or the medications. We like to bring the patient in every 2 or 3 weeks and do topography and refractions, and we basically do that until 3 months, or we get a stable refraction over and over again. Because I don't want to go, again, treat with an excimer laser and treat what isn't the true correction, okay? With multifocal patients, they're often very unhappy because, again, they've spent the extra money and they wanted an instant result, and even though they were counseled to begin with that they weren't going to necessarily get that, they don't seem to remember that after surgery, what they were told before surgery. So, in our case, because we use the aura and everything, the vast majority of our retreatments are less than 1 diopter of spherical equivalent, and most of our treatments are for residual astigmatism, the majority in patients who do not respond well to the LRIs. So again, a number of different ways you can attack this. You can exchange the IOL. You can put a piggyback IOL on top if you're really off. This is not something I have had to do, but is more often something that has to be done, for instance, in a radial keratotomy patient where you get a big hyperopic surprise, and let's say the capsule was open and you don't want to exchange the lens. You can go in and rotate and reposition the toric IOL. Again, you can add or put in relaxing incisions, or you can do LASIK and PRK. IOL exchange, there are many techniques, but the surgeon should be comfortable and willing to perform this if they're doing multifocal lenses, because one cannot predict who will be intolerant of a multifocal lens. It's done best early, and if there's no YAG capsulotomy, late and post-capsulotomy exchanges are possible, but they're more risky and difficult and often require a vitrectomy and a sewn-in intraocular lens. And again, it is often difficult to resolve the role of small amounts of PCO in a multifocal lens because they have way more significance to a multifocal lens than they do to a regular lens. And I use this again primarily for large errors and multifocal lens intolerance. The ideal piggyback patients are hyperopic spherical errors, people who are poor LASIK candidates. Very often they have consecutive hyperopia from radial keratotomy. You must consider that you have adequate anterior chamber depth. Is the endothelium still healthy enough to survive another procedure? Is the primary posterior chamber IOL stable? Is the refraction stable? And are there minimal higher order aberrations? And I think these lenses are definitely contraindicated in people with pigment dispersion, which is glaucoma and increased IOP, pseudoexfoliation, which we know is very high in the Asian population, low endothelial cell count, or a lot of significant astigmatism that in the United States we do not have a piggyback lens that addresses astigmatism.
One thing on the piggyback lens, I don't know, squared edges, you don't want to have a squared edge.
Right. The lens design is, the lens you must select should be a lens that is designed to be piggybacked. The most common in the US is the star lens, and you also want to avoid similar materials in the lens. You like to have different materials because it's been shown that you can get opacification of the interface between the lenses. So what about IOL rotation to determine if your residual error is in an astigmatic lens can be cured by simply rotating the lens? I like to use this site. It's available to everyone, www.astigmatismfix.com. You have to look at your lens, determine what your postoperative refraction and where the lens is sitting, and this will then show you the residual cylinder with rotation. And I'm going to show you an example of this. Again, I find that rotation of an IOL gets more and more difficult as time goes on, especially, for instance, with the Alcon Acrosoft lens, because of the bulbs at the end of the haptics tend to fibrose in very quickly. It's sometimes very difficult to loosen the lens in the capsule. I like to mark the current position because once I get going, I'll lose where I came from. And you're going to see that normally what this tells me is how many degrees to rotate from where I am. I use visco dissection to dissect the haptics free and rotate them. Oftentimes I'll put a 30 gauge needle on the viscoelastic. I'll go into the eye and I like to go at the junction of the haptic and the optic, and with the bevel down, work my way under the capsule where it's stuck down in a little moving motion there, being careful not to rotate the needle and cut the capsule, and inject viscoelastic as I go in. Once I get a separation there, then I'll go back and switch to the regular blunt viscoelastic cannula and try to open up, follow the haptics down to the bulb, and inflate the capsule to free the lens. Unfortunately, if you rotate it and it's not truly free, it'll look like it's good, and then the next day it'll slide back to exactly where it was. So this is astigmatism.com here, and this is the current refraction. The patient is -350 with a cylinder of +325 at 89.9 degrees. This is the toric lens that was put into the eye. Okay. This tells you that the ideal position of the lens is 115 degrees, and if the lens is rotated from 100 to 115 degrees, then the residual astigmatism is only 0.45. And this is the rotation curve. Here's the position, and here is the position of least astigmatism. And sometimes when you run this formula, what you'll see is, let's say, it'll only dip down to 1 diopter, okay? Because you didn't put in a high enough power astigmatism lens. So when you see that, then you know that rotation will improve the astigmatism, but it won't reduce it to close to zero, and that may influence your decision from rotation to an IOL exchange for a higher power toric lens. So again, LRI requires a regular astigmatism. There's a spherical equivalent. If you're going to add an LRI post-operatively, should be very close to plano. There is a little bit of coupling that tends to make a slight hyperopic shift when you add LRIs. So a spherical, remember spherical equivalent is the sphere plus the cylinder divided by 2. So here, with a -2 + 4 at 90, I know that my spherical equivalent is very close to 0, and if I can correct this astigmatism, I will have success. There are multiple nomograms available, as Dr. Thuyen alluded to, on the internet. LRI planner, Donenfeld nomogram, Nickerman nomogram, and variations of this have to be made versus a blade versus a femto. Femto incisions tend to be more effective because the depth tends to be better regulated and you get a more consistent result. And there are now a number of laser platforms that will allow you simply to place laser LRIs post-operatively. So what's the advantage of these? They're easy to perform. They're relatively reliable. I like Eric Donenfeld's little angulated blade, and I will actually do LRIs at the slit lamp. Again, if the pre-existing LRI is there and it's on the incision, on the axis of the residual astigmatism, I can try reopen it. I can try extend it a little bit, keeping the axis exactly the same. It's very, very important, though, never to add opposing limbal relaxing incisions to previously placed ones. So if you have incisions at 90 degrees and you have residual astigmatism at 180 degrees, do not put LRIs at 180 degrees. You will destabilize the cornea and it will become very irregular, and it will often even progress into a very bad situation. It actually brings us back to the days when people were trying to do a hyperopic RK procedure, and it worked at first, but then the corneas all went very badly. So LASIK and PRK are generally my method of choice. Part of that is because I have easy access in my office to the excimer laser. You can correct both, of course, the residual sphere and cylinder. You should know that these enhancement options are viable before the lens is implanted. I've seen a number of reported cases where topography was not done preoperatively, and then postoperatively, when they go to do the topography to plan the LASIK, they realize the patient has keratoconus or a form-fruste keratoconus, and the options are not available. When I wrote this talk about a year ago, I tended to do way more LASIK than PRK because I like the accuracy and I like the quick return to good vision. But I have had a number of older patients with persistent flap edema after LASIK, and I don't find that I can predict who these people are, so I've actually found myself shifting more and more to PRK. The other thing that's great for PRK is that for people who are not really experienced laser vision correction surgeons who have done a lot of LASIK and aren't comfortable with the flaps, the PRK is much simpler. And again, generally these are very low corrections and no nomogram adjustment is necessary. So again, I've just outlined sort of the characteristics here with LASIK. You may have an old flap that you might want to lift if it's relatively new for some reason. I don't lift flaps after 1 year anymore because of epithelial ingrowth. I will do a PRK over an old LASIK flap. LASIK is faster recovery, minimal discomfort, again with the risk of epithelial ingrowth with a flap lift, and TLS or transient light sensitivity I have seen with my patients. This is a much more expensive way to do it than PRK, which is easier to learn. You don't have to worry about basement membrane issues. In fact, you often treat them. No flap issues. Unfortunately, a little bit longer healing time. I say no more pain, but I find that the patients who have the cataract age are very tolerant of PRK. It has very equivalent outcomes and it's less expensive. Mostly mitomycin because it's a very small correction is not necessary, but I would encourage you to use mitomycin if you're doing PRK on a LASIK flap, on old LASIK flap. So this was a retrospective study that we did looking at all our premium IOL cases in 2013. This was LRIs with a monofocal lens, toric lenses, and multifocal. The desired target for all of these eyes was emetropia. We looked at 53 eyes in 41 patients, 10 of which were bilateral. The results were done to the nearest Snellen acuity. 44 were done with LASIK, and 7 were done with PRK. These were all wavefront optimized LASIKs. This was, for me, about a 13% enhancement rate on my premium IOLs, but it also included people who got multifocal lenses and had astigmatism enough that we knew we were going to have to do LASIK, because in the United States we currently have no toric multifocal lenses available that are approved by the FDA. So this was my pre-enhancement spherical equivalence. This is +1, this is -1. You can see that the spherical equivalent in almost all of the patients was within 1 diopter. Oh, we're done. Sorry, that just crashed for some reason. Okay, here's the, here's the pre-enhancement astigmatism. And you can see there was a very wide range here, going up to 3.5 diopters of astigmatism. This was a multifocal patient that we knew that we could not correct with limbal relaxing incisions, so this was planned, as was the 2.5. So most of these corrections over 1.5 diopters are planned enhancements, because I don't do limbal relaxing incisions for any more than 1.5 diopters. After enhancement, this is the uncorrected visual acuity of 51 eyes in the 41 patients. You can see 12 patients achieved 20/15, 19 20/20, 16 20/25, and 3 20/30, and 1 20/50. The reasons for the 3 or 4 patients that were outside of the 20/30 range is that the 20/50 patient had a best spectacle corrected visual acuity of 20/40 due to age-related macular edema, and 1 patient, status post prior LASIK and PRK, did have this residual after enhancement, and another patient had this residual but very persistent ocular surface disease. I know that these 2 patients actually got better and never were enhanced again. So things that I have worried about when I operated enhanced over premium IOLs is when we make LRIs and now we want to cut a laser flap over the top of it, that's kind of scary. When you lift the LRI, is it going to have a hole in it? Does it have a tear? And I've had no difficulty with LRIs being inside my femto LASIK flap. I've not had any epithelial ingrowth or any complications. I've worried when the astigmatism of the laser vision correction over the toric IOL was not additive, but at a completely different axis, would I cause visual acuity or visual quality problems? And I have not seen that. Also, a lot of people do not recommend large astigmatic corrections over a multifocal, yet I've had excellent results doing this. So my goals with these patients is to do the least number of procedures to attain a great outcome, take the least risk, achieve the goal in the shortest time, and most important, have a happy patient.